Hello, welcome to a new tutorial presented by the SchrDbb. So in this tutorial, we are going to continue with the diagnosis of premature rupture of membranes. So when you want to give a diagnosis, we continue with the diagnosis of premature rupture of membrane. When you want to give the diagnosis of premature rupture of membrane, you need to bring out So you need to know that when you want to put a diagnosis of premature rupture of membranes, you should start, as I've already explained, based on the SchrDbb algorithm. You have the disease, the differential diagnosis, endemic disease. You have the cause, then you have the complication, and then outside you have the background, and then later on you're going to have a prognosis. Now, so in the diagnosis, when you want to give your diagnosis of the premature rupture of membrane, you start by saying that they will have a premature rupture of membrane. And now it has to be, generally premature rupture of membrane is divided into three. The first part, you have a term, it can be term premature rupture of membrane when it is after 37 completed weeks of gestation. And I've already explained that 37 completed weeks of gestation is 36 weeks, 67 days. Basically 36 weeks 7 days. Now it can also be preterm premature rupture of membrane, provided that the rupture of membranes occur less than 37 completed weeks of gestation, but after the age of viability. Basically, in our context, age of viability is 20 weeks of gestation. That's the context Cameroon. Now, after preterm premature rupture of membrane, we also have pre-viable premature rupture of membrane that generally we can use in our context. Similarly, because generally we need to know that the age of viability in out of our context, that is in mostly in Europe, is going to be considered 22 weeks of gestation. But in our context, the age of viability is at 20 weeks of gestation. So it means that there is a high probability that the child is capable of living in between 22 weeks of gestation and 28 weeks of gestation. That's why it's best called to be pre-viable premature rupture of membranes than a missed abortion. Now, if you have now a child that is, you have a rupture of membrane. If you have a rupture of membrane before 22 weeks of gestation, here in this case the viability is extremely low, so that's why it's going to be called an inevitable abortion. Basically an inevitable abortion. So those are the different this is how you bring out your diagnosis. You bring out the diagnosis by saying that you have a premature rupture of membrane. You say this the classification in which you are. Is it term, is it preterm, or is it pre-viable? Basically. So after saying the classification, you must speak about the complications of the premature rupture of membranes. Basically, and I've already spoken about the complications of the premature rupture of membranes when we were doing the part of the pathophysiology. I said that the complications is divided into the complications are associated with oligohydramnios, which is associated with the loss of the amniotic fluid. We have the complication associated with the portal or point of entry, the portal of entry. We have also the complication associated with the prostaglandin increase, So those are the different complications pathophysiology that we can have. I've said that under oligohydramnios, the major element that we must bring out is acute fetal distress. You have acute fetal distress that you must bring out. And I've forgotten also to tell you that you have the complication pathophysiology related to a premature birth. We have also complication related to premature birth. So those are the four major pathophysiologic complications that you can have in the case of premature rupture of membrane. In this case of oligohydramnios, the acute complication that you can have an acute fetal distress. You can have also malpresentations. Now the chronic complication now is going to be associated with abnormalities of the functioning of the structures, because you need to know that what the amniotic fluid is usually used in the growth of the GIT. So you're going to have duodenal atresia and all that. You can have also renal hypoplasia. You can have lung hypoplasia. Now in the case of premature birth, we have from the complication that we have related to the premature birth, we are going to have elements like an immature lung. Is it clear? An immature lung which occur in a case of a prematurity. Is it clear? Prematurity. And then now in this premature lung, we have what is called an acute respiratory distress syndrome. Is it clear? And this acute respiratory distress syndrome is as a result of a low level of surfactant. Is it clear? Low level of surfactant. Now, generally, you have to know that what surfactants are going to be produced, start to be produced at 28 weeks of gestation, and then complete. So it starts to be produced as 28 weeks of gestation, but complete surfactant production and growth of the lungs is going to end at 34 weeks of gestation. Basically, so if you have a child who is less than 34 weeks of gestation, there is a probable lung immaturity. So you need to mature the lungs before the child has to get born. Is it clear? So we have immaturity of the lungs in the case of prematurity. We can have also intrauterine growth restriction. Basically, intrauterine growth restriction, which can be associated with a premature birth. Now, for the point of entry, we have already spoken about infection, and then the next one, which is an increase in prostaglandin, and that particular infection is called chorioamnionitis. Is it clear? Chorioamnionitis, and for the prostaglandin increase, you're going to have preterm labor. Basically. Now, those are the different elements that you must visualize as a complication of the prematurity, as a complication of premature rupture of membranes. Now, let's come back now to the next part of our tutorial, which is the cause. So you have to speak about also the cause in your diagnosis. Is it clear? And we said that the cause is related to either the etiology of an increase in intra-abdominal pressure, or you have anything that can fragilize the membrane. Is it clear? And we said that inside the increase in intra-abdominal pressure, you can have anything that can increase the intrauterine pressure, or any other thing that can increase the intra-abdominal pressure. Is it clear? Anything that can increase the intrauterine pressure, we said multiple gestation, we said macrosomia, we said uterine synetia, we said a fibroid. Is it clear? We said also a polyhydramnios. But now the other thing that can increase intra-abdominal pressure, we have things like chronic cough. Is it clear? If the patient has chronic cough, or the patient is a weightlifter, is it clear? Normally, you should not lift weight during pregnancy. If she lifted weight during pregnancy, it can be a cause of premature rupture of membrane. Or if the woman is having a retention, is it clear? If she's having retention because of a previous mass, is it clear? It can also increase in intra-abdominal pressure. And now we said anything that can fragilize the membrane, we can have things like cervicitis. We are going to have things like cervical incompetence. We talked about cervical coning, and then the last element here, we're going to have anything like if you have a cervical mass, like a cervical polyp, a cervical cancer. So all that can fragilize the membrane. Is it clear? So that is how you are going to put your diagnosis of a premature rupture of membrane. Now we continue with the investigation.